Welcome to Lecture Boss. My name is Dr. David Averbach, and today we will be discussing breast disorders. We have a student in the hot seat today who will be answering my questions. We will divide breast disorders into benign and malignant conditions. We will further divide benign disorders into neoplasms, inflammatory disorders, and fibrocystic changes. Let's first discuss some of the diagnostic tests for breast disorders. What are the two most common imaging modalities, and which patient populations are they used in?
Ultrasound is preferred for women under 30 because of their increased breast density, and mammography is preferred for women over 30.
Correct. There is also breast MRI, which is used to screen high-risk patients, for example, with BRCA mutations. It has more sensitivity than mammography, particularly in women with dense breasts, but less specificity. Name 3 methods for breast biopsy and advantages and disadvantages of each.
So the first method is fine needle aspiration, which is the least invasive, but you don't get as good of a tissue sample. It's useful for determining if the mass is a fluid-filled cyst. Then core needle biopsy is more invasive, but yields a better sample and can more accurately determine tumor type and receptor status. You can do histology and determine if the tumor is invasive or non-invasive. And last, excisional biopsy is the most invasive and can be used if the mass is very large or core needle biopsy results are inconclusive.
Correct. Let's start with benign breast disorders, which include neoplasms, inflammatory disorders, and fibrocystic changes. What are some characteristics of benign breast masses?
Benign breast masses would be more likely in a woman under 40 with no family history. The mass would be mobile, have well-defined borders, and may fluctuate in size with the menstrual cycle.
Correct. Additionally, the skin would more likely be normal, and there wouldn't be any axillary lymphadenopathy. Name 3 benign breast neoplasms.
3 benign breast neoplasms include fibroadenoma, intraductal papilloma, and phyllodes tumor.
Correct. Lobular carcinoma in situ is also considered a benign neoplasm, but it increases the risk of developing invasive carcinoma in either breast. What is the most common age range for a fibroadenoma, and what are the physical exam findings?
It's found in women between 20 to 35 years old with a single mass in one breast that's mobile, non-tender, and rubbery. It doesn't usually grow with the menstrual cycle.
Correct. It's usually 1 to 2 centimeters. It's a tumor of both stromal and epithelial cells. How do we manage a fibroadenoma, and is there malignant potential?
No biopsy or treatment is needed unless it's physically disfiguring. There's very low malignant potential.
Correct. Giant fibroadenomas are greater than 5 centimeters and usually develop during puberty or pregnancy. They are surgically excised. What is the most common age range for an intraductal papilloma? And what are the physical exam findings?
It's found in women between 35 to 55 years old. It presents with serous or bloody nipple discharge and a mass behind the nipple or areola.
Correct. Intraductal papillomas arise from epithelial cells lining the ducts, and they are the most common cause of serous or bloody nipple discharge. You must also consider malignancy with bloody nipple discharge, as we'll discuss later. Younger women more commonly present with multiple papillomas located peripherally. These have more malignant potential. Perimenopausal women present with solitary central masses. More lifetime exposure to estrogen increases the risk of intraductal papillomas. How do we manage an intraductal papilloma?
For intraductal papillomas, ultrasound or mammography is the initial test. You'll see a mass in a dilated lactiferous duct.
Correct. Core needle biopsy is done for confirmation to rule out cellular atypia. If no atypia, you can do surveillance. If atypia is present, perform excision of the duct. What is the most common age range for a phyllodes tumor? And what are physical exam findings?
A phyllodes tumor occurs between 40 to 50 years old. It presents with a painless, large, nodular lump in the breast.
Yes, this is a rare tumor and can be up to 6 centimeters. Is it a tumor of both stromal and epithelial cells? Does a phyllodes tumor have malignant potential?
Yes, it has malignant potential and can metastasize, so it needs to be biopsied with either core needle or excisional. It exhibits a leaf-like architecture on histology. Phyllodes tumors are usually surgically removed.
Correct. Let's discuss fibrocystic changes of the breast. Fibrocystic changes can be non-proliferative or proliferative. What is the most common age range and physical exam findings?
Fibrocystic changes occur between 20 to 50 years old. It presents with multiple masses in both breasts and premenstrual tenderness. I'm not sure if they get bigger during the menstrual cycle.
The masses fluctuate with hormone levels. They increase in size before the menstrual cycle starts and shrink in size after it starts. How big are the masses in fibrocystic changes?
They're usually 1 to 3 centimeters in size.
Correct. Is there nipple discharge?
There may be a clear or white nipple discharge.
Yes. Non-proliferative subtypes of fibrocystic changes include simple breast cysts and apocrine metaplasia. Proliferative subtypes include sclerosing adenosis and ductal hyperplasia. The proliferative subtypes have an increased risk of malignancy, particularly if they have cellular atypia. If a simple breast cyst is detected on ultrasound or mammography, how do you manage it?
You perform fine needle aspiration. If the fluid is clear and the cyst flattens, no further workup is necessary. But if the fluid is bloody, you do a core needle biopsy.
Yes. If the ultrasound had initially revealed a complex cyst, thick walls, septations, solid and cystic components, we would have done core needle biopsy because of the higher risk of malignancy. What if the woman returns a few weeks later after draining a simple cyst and the cyst has enlarged again?
Then you perform a core needle biopsy.
Correct. If an ultrasound or mammogram showed features concerning for sclerosing adenosis or ductal hyperplasia, what would be the next step?
This would also warrant a core needle biopsy.
What if this biopsy shows sclerosing adenosis or ductal hyperplasia with atypia?
Then you would do a surgical excision.
Correct. What if a cyst forms in a woman who is breastfeeding or after she completes breastfeeding?
That's a galactocele, where a lactiferous duct is obstructed and the milk accumulates in a cyst.
Yes, describe this mass.
A galactocele is soft, painless, and fluctuant, and it may change in size.
What would you see on imaging?
Ultrasound may show a fat fluid level in the cyst.
Yes, ultrasound is more sensitive than mammography in lactating and pregnant women. How would you treat a galactocele?
No treatment is usually required, but you can do fine needle aspiration if there are any symptoms like pain or swelling.
Correct. Let's discuss inflammatory disorders of the breast. Name an inflammatory condition in a breastfeeding mother.
Infectious mastitis.
What is the pathophysiology?
The baby creates cracks in the nipple when breastfeeding, and then Staph aureus enters the milk ducts.
Yes, there's an increased risk of infectious mastitis in any condition that creates milk stagnation, such as breast engorgement. What are the symptoms of mastitis?
You can get fever and a red, painful, swollen breast.
Correct. There are some breast malignancies that can present the same way, which we'll discuss later. What is the treatment for mastitis?
So the mother should continue breastfeeding to reduce the risk of milk stagnation. Antibiotics should be given that cover for Staph aureus, such as dicloxacillin or cephalexin.
Yes. What are the complications if mastitis is not properly treated?
A breast abscess.
And what are the clinical features and treatment of a breast abscess?
Fever and a red, painful, swollen breast and a fluctuant mass. You should drain the abscess and give the same antibiotics as in mastitis.
Correct. Make sure to contrast breast abscess with galactocele, which is also a fluctuant mass in a breastfeeding woman. However, Galactocele will not have a red, painful breast or fever. Let's discuss fat necrosis of the breast. What is the etiology of this disorder?
Trauma to the breast or surgery.
Correct. What are the clinical features of fat necrosis?
A firm, irregular, painless mass.
You can also have skin dimpling or retraction, or nipple inversion that resembles breast cancer. What are the imaging findings in fat necrosis?
Mammography may show an oil cyst. It may also show coarse calcifications or spiculations similar to a malignant tumor.
Correct. How would you manage fat necrosis?
It's usually expectant management, but you may have to biopsy if it shows calcification patterns or spiculations suggestive of malignancy.
Yes, you may have to excise to rule out malignancy or so that the fat necrosis doesn't hide a future underlying cancer. What would you see on biopsy?
You would see foam cells and multinucleated giant cells.
Correct. Let's discuss mammary duct ectasia. What is the age range and pathophysiology of this disorder?
Mammary duct ectasia occurs between 40 to 50 years old. It involves inflammation and dilation of the lactiferous ducts.
Correct. What are the clinical features?
Green or gray nipple discharge, nipple inversion, and breast pain.
Yes, there may also be a subareolar mass. What is seen on ultrasound or mammography?
You see dilated lactiferous ducts.
And what is the treatment of mammary duct ectasia?
Most cases resolve on their own. You can do surgical excision of the ducts if symptoms persist.
Correct. Let's discuss malignant tumors of the breast. What are the risk factors for malignant tumors?
A malignant tumor would be more likely in a woman over 40 with a family history or inherited gene defects.
Yes, most cases of malignant tumors are postmenopausal, and half are over the age of 65. Name some gene mutations that increase the risk of breast cancer.
A p53 tumor suppressor mutation, as seen in Li-Fraumeni syndrome, and BRCA1 or BRCA2 tumor suppressor mutations.
Correct. Other mutations that increase your risk of breast cancer include the P10 tumor suppressor, seen in Cowden syndrome, and the STK tumor suppressor, seen in Peutz-Jeghers syndrome. Tell me about mutations in hormone receptors.
A woman can have mutations in the estrogen, progesterone, or HER2 receptors, leading to increased signaling and cellular proliferation.
Yes, sometimes mutations cause an overexpression of receptors. Other mutations cause the receptor to be overly sensitive to hormones. Other mutations cause the receptor to signal in the absence of hormonal stimulation, which can also be a mechanism of tumor resistance to therapeutics. What about hormonal risk factors other than receptor mutations?
A major risk factor is increased endogenous estrogen exposure from more menstrual cycles. For example, they didn't have children or breastfeed, or they had their first child after 35, or they had early menarche and late menopause. Obesity is also a risk factor. Another risk factor is taking exogenous estrogen, like combined oral contraceptives or hormone replacement therapy for menopause.
Correct. Hormonal contraception increases the risk of breast and cervical cancer, but reduces the risk of endometrial and ovarian cancer. What about other risk factors, such as ethnicity and lifestyle?
Breast cancer is more common in Caucasians, although triple negative breast cancer is more common in African Americans. Smoking, alcohol, and a high-fat diet are also risk factors.
Correct. A few other risk factors include having breast cancer in the contralateral breast, radiation in childhood, and some of those benign breast disorders we discussed with cellular atypia. What are the clinical signs of a malignant tumor?
It's more likely to be in the upper outer quadrant. The mass would be firm, fixed, have indistinct borders, and may increase in size. There may also be skin changes and axillary lymphadenopathy if it metastasizes.
Correct. The breast may also appear asymmetrical, and there may be nipple inversion or bloody nipple discharge. What are the imaging findings of a malignant tumor?
With a malignant tumor, mammography or ultrasound may show a mass with irregular shape, indistinct border, and spiculations. There will be calcifications.
Yes. On mammography, a malignant tumor may also have clustered microcalcifications, while a benign tumor will more likely have diffuse or coarse microcalcifications. Let's discuss some of the different types of malignant tumors. Most breast cancers are epithelial tumors that develop from cells lining the terminal lactiferous ducts or milk-producing lobules. Malignant tumors can be non-invasive or invasive. Tell me some of the types of malignant tumors.
Well, ductal carcinoma in situ is a tumor of cells lining the lactiferous ducts that hasn't penetrated the basement membrane. It can progress to invasive ductal carcinoma when it penetrates the basement membrane.
Correct. Invasive ductal carcinoma is the most common invasive breast cancer, and it's usually unilateral with one mass and very aggressive. What are findings on mammography?
Irregular shape, spiculations, and clustered microcalcifications.
Correct. There is a subtype of invasive ductal carcinoma called medullary breast cancer. It's the most common type of breast cancer in BRCA1 carriers and is often triple negative, which confers a poor prognosis. Name another type of invasive carcinoma.
Well, you have lobular carcinoma, cancer of the cells of the milk-producing glands. It can be bilateral, and there can be multiple tumors in each breast.
Correct. What are associated gene mutations or histology findings for invasive lobular carcinoma?
There are mutations in genes encoded in E-cadherin proteins necessary for cell-cell adhesion. On histology, the cancer cells are arranged in single file lines.
Correct. We discussed several benign breast disorders that cause redness of the breast. Can you name two malignant conditions that cause redness of the breast?
Paget's disease of the breast and inflammatory breast cancer.
Correct. How does Paget's disease of the present, and what is the underlying pathophysiology?
Paget's presents with an erythematous rash of the nipple and areola. This rash occurs when malignant cells from ductal carcinoma invades the lactiferous ducts and epidermis.
Yes, that's one theory. A biopsy of the nipple will show Paget cells within the epithelium. These are large cells with clear cytoplasm and a prominent nucleus. How would you diagnose and treat Paget's?
We would do imaging to look for underlying ductal carcinoma and treat with lumpectomy or mastectomy.
Correct. What are the clinical findings in inflammatory breast cancer?
Tumor cells invade dermal lymphatics and cause obstruction. This causes the breast to look inflamed, meaning it's red, warm, and swollen with prominent hair follicles and thick skin, or an orange peel appearance.
Yes, this is a form of invasive ductal carcinoma, and it usually has spread to the lymph nodes or distant sites at the time of presentation. It can resemble mastitis. The patient may or may not have a palpable breast mass. They might also have bloody nipple discharge. In addition to imaging and core needle biopsy, what else is required for diagnosis of inflammatory breast cancer?
Diagnosis will include a full thickness skin biopsy, which may show tumor cells in the dermal lymphatics.
Correct. Let's discuss treatment options for breast cancer. Modalities include surgery, radiation, and systemic therapy, such as chemotherapy, hormonal therapy, and targeted therapy. Describe some of the surgical options for breast cancer.
You can do breast conserving surgery or lumpectomy, where you excise the tumor with clear surgical margins as determined by histology. Or you can do mastectomy, where you remove more extensive tissue.
Correct. What are the types of mastectomy and the differences between each?
There is total, modified radical, and radical mastectomy. In total mastectomy, you remove the nipple, areola, and breast tissue. In modified radical, you remove this tissue, but you also remove some of the axillary lymph nodes. And in radical mastectomy, you additionally remove pectoral muscle.
Yes, and you will perform sentinel lymph node biopsy during these surgeries to determine if you need to do an axillary node dissection, which can have many complications. What are the advantages and disadvantages of a lumpectomy and mastectomy?
With a lumpectomy, you conserve more breast tissue, but there's more cancer recurrence. This recurrence can be reduced by doing radiation following lumpectomy. Survival would be the same in a lumpectomy with radiation versus total mastectomy. A modified radical mastectomy has the same survival as a radical, but with less morbidity.
Correct. What are some contraindications to doing lumpectomy?
We don't perform lumpectomy if there are multiple tumors in multiple quadrants of the breast, or a large tumor to breast volume ratio.
Correct. If a woman is pregnant, she can't receive radiation, so you may not want to perform lumpectomy. Also, lumpectomy isn't done for inflammatory breast cancer. If you do lumpectomy followed by radiation and the tumor recurs, then you will do mastectomy. A bilateral prophylactic mastectomy is indicated in high-risk patients, such as those with BRCA1. What are complications of mastectomy and axillary lymph node dissection?
During mastectomy, you can damage the long thoracic nerve, causing medial scapular winging. Axillary lymph node dissection and radiation can cause lymphedema of the arm.
Yes. What's a complication of long-standing lymphedema?
I'm not certain.
Lymphedema can lead to angiosarcoma of the breasts, a cancer of endothelium of blood vessels of the skin that presents with purple macules or papules. Let's discuss systemic therapies. The systemic therapy you choose depends on receptor status and menopause status. All breast cancers are tested for hormone receptor status, and there are three that you should know: the estrogen receptor, the progesterone receptor, and the HER2 surface protein. The receptor status is determined by a pathologist testing the tumor tissue removed during a biopsy. These biomarkers can either be positive, where they are expressed in the breast cancer tissue, or they can be negative, where there is little to no expression in breast cancer tissue. Triple positive breast cancer typically has a more favorable prognosis compared to triple negative breast cancer because triple positive breast cancers respond well to medical therapy currently available. If the patient requires both systemic therapy and radiation therapy, do the systemic therapy first. Systemic therapy administered before surgery to shrink the tumor is known as neoadjuvant therapy, and that administered after surgery is known as adjuvant therapy. What are some systemic therapies, and when do we use them?
Only postmenopausal women that have estrogen receptor positive breast cancer can use aromatase inhibitors such as letrozole, anastrozole, or exemestane. Aromatase inhibitors lower estrogen levels by stopping the enzyme aromatase in fat tissue cells from converting other hormones into estrogen. On the other hand, both premenopausal and postmenopausal women that have estrogen receptor positive breast cancer can use tamoxifen, which is a selective estrogen receptor modulator. If she has ERB2 or HER2 positive breast cancer, we can use trastuzumab, which is an epidermal growth factor receptor 2 blocker.
Correct. In premenopausal women, you can also combine tamoxifen with GnRH agonists, such as leuprolide, to suppress ovarian function. This has improved outcomes. Tamoxifen can also be used for breast cancer prophylaxis in high-risk women over 35 who are premenopausal. If the woman is postmenopausal, you can use aromatase inhibitors or the sermraloxifene for breast cancer prophylaxis. What are some side effects of these systemic therapies?
So tamoxifen can cause blood clots and endometrial hyperplasia. Trastuzumab can cause dilated cardiomyopathy.
Correct. If you're going to give trastuzumab, you must do an echocardiogram before, during, and after therapy. For metastatic breast cancer, we will add other chemotherapeutic agents to these hormonal therapies or targeted therapies, such as doxorubicin or paclitaxel. We will also use these chemotherapeutic agents for triple-negative breast cancer. Other options for metastatic estrogen-positive breast cancer include cyclin-dependent kinase 4 and 6 inhibitors, such as palbociclib. This can be combined with tamoxifen. Poly-A-ribose polymerase inhibitors, such as olaparib, can be used for cancers that are BRCA positive. What are some complications of having breast cancer?
Breast cancer can cause a malignant pleural effusion or a pericardial effusion.
Correct. Breast cancer can also have paraneoplastic syndromes, most commonly cerebellar degeneration. What are some sites of breast cancer metastasis?
Breast cancer most commonly metastasizes to the bones, liver, lung, and brain.
Correct. Finally, let's discuss screening guidelines for breast cancer. What are the guidelines for the USPSTF, American Cancer Society, and ACOG, the American College of Obstetrics and Gynecology?
USPSTF recommends mammography every 2 years, starting at age 40 until age 74. The American Cancer Society recommends mammography every year, starting at age 45 until the woman's life expectancy is less than 10 years. And ACOG recommends mammography every 1 or 2 years, starting at age 40 until age 75.
Correct. Thank you for joining us for our lecture on breast disorders. We hope you learned a lot. Additional notes on this topic will be available at lectureboss.com or by following the link in the video. Take care.